Well, good afternoon, everyone, at least to those in the Eastern time zone. Good morning to everyone else, and welcome to the first of two webinars for our project having to do with drivers of health. This is a Robert Wood Johnson Foundation supported project that's been coordinated by Harvard Global Health Institute. And a couple aspects of the title I think are worth noting as we get started today. New knowledge on drivers of health. The question about what determines health in a population or what drives health is certainly not a new one, but the field keeps evolving. There are new questions and new answers being developed. And as this project began a little while ago, it seemed important to look again and see what we've learned. And then particularly looking at questions about health equity. That has not always been part of this discussion in the past, but it is certainly relevant to us now. So much of what we have to talk about that came out in this project is not just about drivers of health in the traditional sense, but also what are the determinants of health equity. So I think you'll see that woven through some of the presentations we have to share with you in these two webinars. Okay, if we can go to the next slide, thanks. As I said, Robert Wood Johnson Foundation was the funder of this project. It began over a year ago, led by Dr. Frack, and with a steering committee supporting that work. And it started with an in-person meeting over a year ago in Princeton, where we had a number of presentations by experts on various parts of this large topic. There was a meeting in Detroit last September that focused on particularly housing and education as determinants of health. There was then an in-person meeting in Cambridge last December, focusing on a couple other aspects. And all of those were sort of enriching the discussion of what will then ultimately come out as a report for this. But as this has been going on, there was also a solicitation for a special issue of the Journal Health Services Research to get specific, new, interesting empirical papers on this general theme. And so the two webinars are going to talk about some of the papers that are in that special issue. This is what the special issue looks like if you see it in print version. Just came out a little while ago. It has 14 papers, all of them open access, and we appreciate sponsor support for that. Patrick Romano is the editor-in-chief of the journal, but Austin and I served as guest co-editors for this issue. You see the link there. If you want to go get it online, it's available. So even though we are featuring some of the papers on these two webinars, there are 14 really excellent papers that I'm sure you'll find interesting if you check out the special issue. So for today, what we have are three 15-minute presentations. Again, they're drawn from papers in the special issue. We're going to move through them one after the other. After each one of the presentations, I'll ask maybe one or two sort of clarifying questions, but we'll try to move it along so that in the last 10 minutes of our hour, there's an opportunity for those who are attending to ask questions. And you can address questions via the chat function, the Q&A function, to individual presenters. You could also do it to more than one presenter if you see an issue perhaps of common theme or common interest. So we'll be monitoring those as we go along, and we'll choose some of those to work into the discussion at the end. So what we have are three excellent presentations. First of all, from Dr. Farouk Alami, who's a professor at George Mason University, who's studied the accuracy of social and medical determinants of suicide risk in medical records. We'll then hear from Emma Boswell-Dean, who is at the University of Miami, with a very interesting study on the relationship between food insecurity and healthcare expenditures and healthcare utilization. And finally, we'll hear from Margaret McConnell and Kodka, both from Harvard University, from the School of Public Health and the Global Institute, on the issue of in utero exposure to threat of eviction and birth outcomes. So 3 different papers, all interesting topics. And without further ado, I think, Dr. Alemi, we can begin.
I suppose you can hear me now. So I'm
Yes.
going to. Okay, great. This project was funded by Center for Disease Control and Prevention through an award to Lorna Thorpe at NYU. So we were trying to address the issue of what causes suicide, and the issue is important in a very practical sense, because if you modify something that's not the cause of suicide, but it is a predictor of suicide or is associated with suicide, you don't reduce suicides. You have to modify the root causes of the risks of suicide before you can actually see reductions in suicide. So we were asking ourselves, are social determinants or illness or injury are the causes of suicide? The study was done on 5 million veterans that we had access to their complete medical records for the years 2008 through 2016. Among these veterans, there was a rate of 1.89% of suicide and intentional self-harm. Every time I talk about this issue of suicide, which I abbreviated, I include intentional self-harm, but I don't mention it every time. In the VA, suicide rates continue to be a problem, despite the fact that there has been enormous investment and effort in reducing the suicide rates. We examined 10,495 predictors of suicide to see which one are significant predictors. Among these, 40 of them were clearly social determinants of illness. And all of our work is limited by the fact that it's within the electronic health record. What do we mean by social determinants? There are, inside the electronic health record, there are V and Z codes for homelessness, isolation, conflict with your spouse, unemployment, poverty, court involvement, family disruption, and lack of education. A very interesting feature of these codes is that these codes are only recorded if the social determinant interferes with delivery of healthcare. So it is a a particular type of social determinant that is interfering with the delivery of healthcare. What are some examples of the medical and mental and other illnesses that we looked at? These are things like history of self-harm, history of substance abuse, history of certain diseases that are indicative of very late stage depression or disease, um, uh, and also psychiatric and mental illness. So there are lots of information on history of various illnesses, and there were only 40 social determinants. Despite, and perhaps because of, it shouldn't be surprising because there's a lot of information on this, social determinants of illness, the ones that we looked at, which these 40 codes that occur in about 12% of the population that we were examining, were highly predictive, not highly, moderately predictive in cross-validation of suicide. So yes, social determinants are associated with suicide. But illness and injury were also predictive of suicide, and they were more accurately predictive of suicide. So the area, cross-validated area under the receiver operating curve for illness and injury was 77%. An interesting feature of these data was that when social determinants were put into our equations along with the illness and injury, social determinants were not predictive of suicide. So they were not independent predictors of suicide when illness and injury were accounted for. This describes a particular type of causal relationship where mental illness is causing both the adverse events like homelessness, unemployment, and so on, and it's also causing suicide or intentional self-harm. In this kind of causal relationship, you will see a spurious correlation between adverse events and suicides. So the association will appear when we don't control for mental illness and will disappear when we control for mental illness. And that was exactly how our data looked like. So this tells us that the root causes of suicide is not the stresses caused by homelessness, unemployment, and other activities, but it is the illness and injuries that the patient has faced. Now, before we conclude, I want to go through a series of limitations of our study. First of all, we did not look at every social determinants of health. We did not look at not all social determinants are reported by the clinicians. Not all of the reported social determinants are accepted by coders. So it's a limited set of social determinants of health. We were focused on veterans, and our study may not generalize to other populations. And there is a lot of information that shows that early and late predictors of suicide are quite different. And we were looking at root causes, not later causes. One thing that I should mention, it is quite possible that the history of injury was due to the social determinants of health. And we did not examine that particular issue. So practically, what does this mean? In my view, it means that reducing some risk factors may not prevent suicide. So, for example, reducing homelessness may not prevent suicide. By the way, there is now randomized clinical trials that have shown that reducing homelessness does not prevent suicide. So our study extends that information in a pragmatic way, looking at a large data set and includes um, a variety of social determinants besides homelessness. I think that's my presentation. Am I within the 12 minutes? Oh, you came back on. Good.
You are indeed. Thank you. Not only are you within 12 or 15, you're within 10. Thank you. Gives us a little time for a little more discussion, and also will allow us a little more time at the end. If I could ask you to speculate a little bit about a couple of the points, I'll link them together here. You mentioned earlier the distinction between risk factors and true root causes, and how if ultimately the goal is to prevent suicide, that you want to be able to distinguish those two and then exert the efforts where there's actual causal effect. And then near the end, in one of your limitations, you talked about not being able to really examine a potential causal link that started from social determinants and then went to illness and injury. Um, if I can just ask you to speculate a little bit out that, and I understand you're going perhaps a little beyond the data. Um, do you think there's some fertile territory to explore there, particularly, for example, uh, in a possible relationship between social determinants and mental illness, more specifically than illness in general?
Yeah.
Um, what do we know about that, and is that room for some additional work?
Well, um, definitely there is room for additional work, and I am thinking that it is relatively easy to do this work because you have the sequence of when things have happened inside the electronic health record. So you know whether the person was mentally ill first or whether the person was had the unemployment or had the homelessness first. Um, it seems to me that that kind of sequence data would be really helpful in sorting out what is happening in this data. Um, I don't know if there's anything in the literature that is like that. We are looking at sequence data for reaction to antidepressants, and not in the context of suicide, but in the context of reducing depression symptoms. And there, our studies show that there is interactions both ways. So yes, but that's not published yet. Maybe next time.
Okay. No, and I think we find in your work and in a number of the others that are captured in the special issue, uh, some very complicated statistical relationships that in some sense represent causal networks, but other times represent some risk factors or predictors that are not strictly direct causes. And it's very difficult to sort them out. And you have an example of that here. I'm curious to speculate, but this is an issue that's been tough to untangle. Certainly, going all the way back to my graduate school days. We'll take some more work, but
Yeah. If I can add one comment to that, there is two papers that have been published that have asked everybody to abandon risk factor modification for suicide because it's so futile. It is in that context that's really important to understand why these risk factors modifications don't
right.
result into the changes that we expect. And yes, this answer to this question is far more complicated than what has been portrayed to date. When you, for example, when the Air Force asked for a day of stand down and everybody went through resilience training, you're talking about huge investment of money and resources to reduce stress among people. But what result can we expect from that by reducing suicide? Almost none. And that is what is needed in the literature.
Good, thank you. We should move on, but again, remember, we'll have some time for open questions at the end, including definitely questions for Dr. Alemi. Let's move on then to Dr. Dean.
Wonderful, thank you. So hope you all can hear me okay. So today I'm going to be presenting a paper that was work with colleagues, Dr. Mortensen and Dr. French, that talks about food insecurity and its relationship to healthcare utilization and healthcare expenditure. So food insecurity, which we know is an important social determinant of health, occurs when access to adequate food is really limited by household income. It impacts over 15 million households here in the US, and this is pre-COVID numbers. They have risen. That comprises over 40 million individuals, about 12% of our population. And of these food insecure households, about 40% or nearly 6 million households were considered low food secure or very low food secure in 2017. So this means they actually had difficulty at any point during the year providing enough food for all family members because of lack of resources. And a growing literature really demonstrates that food insecurity is a strong predictor of poor physical and mental health, as well as potentially preventable chronic conditions amongst adults. And theoretically, food insecurity could affect health through a number of pathways. So a less healthy diet than needed to really sustain health. Fluctuations in dietary intake may make management of chronic diseases more challenging. And also the prioritization of food purchases over healthcare needs, things like preventative care or prescription refills. So previous research found that food insecure individuals tend to have greater healthcare utilization and significantly higher annual healthcare expenditures, and has also found that this is really more pronounced for people with chronic conditions. But because chronic conditions are also more common in households with food insecurity, it's really difficult to disentangle the relationship between these two. So in terms of our contribution, unfortunately, we aren't able to get at causal inferences through our paper. The data doesn't allow for it in terms of whether poor health in itself led to higher healthcare spending and therefore food insecurity, or whether food insecurity in itself led to poor health and therefore higher healthcare expenditures. Nonetheless, we are able to improve upon the literature in a number of ways. So one, we employ recently collected data that include relevant outcome and control variables captured in the same data set and time period. We also specify a more detailed definition of food insecurity that aligns with the USDA's criteria. So this would be high, marginal, low, and very low food secure households. We also control for the presence of a number of chronic conditions. So in terms of high, marginal, low, and very low food security, what does this actually mean? Very low food secure households had either eating patterns that were disrupted or food intake reduced at certain points during the year because the household actually lacked money or resources for food. This is versus marginal food secure households, where the households might have problems at times or potentially anxiety about accessing enough food, but in general, the quality, variety, and quantity of their food take were not substantially reduced. And you could imagine these different levels of food insecurity could have different impacts on things like chronic health conditions and healthcare expenditures. So the data we use is the MEPS data, the Medical Expenditure Panel Survey in 2016. This was the first year of data with food insecurity survey questions in MEPS. So we're actually able to look at food insecurity in the same year and tie that in with healthcare expenditure and utilization in that same calendar year. Our sample is over 13,000 adults, and we do focus on the adult population, so 18 or older. Our key predictor variable is a household's level of food insecurity. And again, we follow this USDA definition. And we have a number of very comprehensive social and economic control variables, as well as chronic health condition controls. In terms of our outcomes, we look at both utilization and expenditures. So in terms of utilization, look at inpatient, ED visits, outpatient visits, as well as prescription fills and refills. And on the expenditure sides, we look at the same areas, but also at total healthcare expenditure. And our approach is really to first present some summary statistics. So just calculating average healthcare utilization and expenditures overall and by level of household food insecurity, as well as computing then the percentage of the relevant population with either no healthcare expenditures or with high healthcare expenditures. So this would be about the top 5% overall of healthcare spending. And the nature of our data really warrants a two-part model approach for our regressions. So we estimate this with probit in the first stage and OLS on the natural log of use and expenditures in the second stage. We present marginal effects averaged over the sample just for interpretability. And we do perform a number of robustness tests, for instance, a GLM model, which yield very similar results. So we just show the probit and OLS here. So in terms of characteristics of food insecure households, these households do look different than other households for a variety of reasons. In a variety of ways. So food insecure individuals tend to be older, they're more likely to be female, more likely to be Black or Hispanic, likely to have lower levels of educational attainment. They're also more likely to be low income, have Medicaid or be uninsured, less likely to be married or employed, and more likely to be from the South. And importantly for our study, they're also more likely to have any chronic health condition and have a greater average number of chronic health conditions. So here what we see is just, this is only weighted by survey weights, but otherwise just averaged out. And what you see is total expenditures and then broken down by category overall, and then by level of household food security. So if you look on this top left graph and then look on the right, you'll see very low food secure households. And what you can see is that there's higher total healthcare expenditures amongst this group as compared to households with higher levels of food security. And this is really driven kind of by both sides of the distribution. So there's fewer households here with no healthcare expenditure, or fewer individuals, and a greater number of individuals who fall on the high end of healthcare spending. And we really see this pattern not just in total expenditures, but also under inpatient, ED, and prescription drug expenditures as well. Slightly different pattern though for outpatient expenditures. So looking at utilization, we don't actually see, so the top panel here has just our social and economic controls. The bottom panel also has controls for chronic health conditions. And when we look at utilization, we see kind of regardless of the controls that we use, both outpatient and inpatient utilization don't differ significantly based on household food security level. However, we do see significant differences, particularly in terms of having any utilization of the ED department, kind of again, regardless of controls we use. So very low food secure households have higher levels of any ED usage. And then if we only consider the social and economic controls, we see a pretty similar pattern for pharma utilization, slightly less strong when we have these chronic health controls included. So moving to expenditures, which is one of the main findings of the paper. Again, in the top panel, we only have our social and economic controls. And what we see in the first column is our probit results, which are just indicative of having any healthcare expenditures. And then the second column there would be conditional expenditures, so conditional on the fact you had some expenditure. And what you see is that when we only have these social and economic controls, we do see increased likelihood of having any expenditure and increased conditional expenditure for very low food secure households and low food secure households. However, when we include these chronic health condition controls, these differences largely fall away in terms of significance. So we do still have very low food secure households do have slightly higher likelihood of having any healthcare expenditure, but largely these results fall away. One thing we don't see is if you look kind of at columns 7 and 8, we do see, continue to see increased utilization of the ED department and to a certain extent of pharmaceutical products for lower food secure households. And this in some way differs from previous findings. So one other thing to consider here is that there might be a stronger impact on certain chronic conditions than others. So it would be useful to actually look at each chronic condition separately and see if amongst people who have that condition, whether we see higher healthcare expenditures in that group. And in this way, again, we also somewhat differ from previous findings. So with the exception really of heart disease, where we do see increased likelihood of having any healthcare expenditure as food level of household food insecurity increases, we don't really see the same pattern for other things, especially things like diabetes, high cholesterol, or high blood pressure, where we might expect to see food insecurity leading to higher healthcare expenditures. So in terms of discussion, really our results show that the likelihood of any healthcare expenditure is higher for low and very low food secure individuals. However, once we account for chronic conditions in our various models, these underlying health conditions really mitigate the differences in expenditures by food insecurity. So only the emergency department and some pharma spending remain statistically significant. So our results in some ways do align with previous literature in that we find a statistically significant increase in the likelihood of any healthcare utilization as well as conditional healthcare expenditure as household food insecurity increases. However, once we again incorporate these controls for chronic health conditions, the differences largely dissipate. So this really just suggests that underlying heterogeneity in health status, which we're proxying by the presence of chronic health conditions, is a key determining factor in driving these associations. Now, again, we're not 100% getting at causality, of course, here. In fact, we're not getting at it at all. So for instance, there could be this bidirectional relationship where if you are food insecure, you're much more likely to have this chronic health condition because you can't, have enough healthy food. This could drive things like type 2 diabetes. So again, we don't get at that here, but that's essentially what we're saying is that chronic health conditions do play a very important role in leading to these higher healthcare expenditures amongst food insecure individuals. So that's all for me.
Great, thank you. And if I could just ask you to, again, speculate a little bit, playing right off the last point you made. You have a similar situation to Dr. Alami's where there's a complex causal network and it's a little difficult to sort out where the causal lines go. If I were the benefits manager of a health plan, for example, do you think there's enough evidence here that I might be able to go out and do some kind of a food security support program and feel that I might see some financial return fairly quickly in utilization, or are we not quite there yet?
I think to answer your question, there's still a lot we don't know there, right? So in terms of one thing we do see for certain is even when we adjust for chronic health conditions, we do see higher ED utilization in groups that are less food secure as compared to more food secure households. And so that says that that's, non-optimal usage of the ED, we would assume. We want to keep people out of the ED, keep them otherwise healthy. So you certainly could see some savings, for instance, there. The other thing is we do know that there are higher rates of conditions, things like type 2 diabetes, heart disease, high cholesterol, in populations that have low food security. And we know that proper nutrition is important in managing these conditions. And so just because we're not necessarily seeing that come out in our model doesn't mean that we couldn't have savings. And actually one difference between our paper and previous papers, so there was another paper published in HSR in 2018 by Berkowitz and co-authors. And they actually did find higher healthcare expenditures for people with chronic health conditions who were food insecure. One difference between our studies is we're looking in the same time period. They were looking at healthcare expenditures 1 to 2 years after a report of being food insecure. And so one thing is we're looking at short-term impacts. They were looking at long-term impacts. And that's one way to reconcile our results is that we might not see these things happening right away, but 1 to 2 years from now, you could be seeing, healthier people, lower healthcare expenditures.
Good. Thank you. Again, for folks listening, please put in questions. We'll be able to cycle back at the end if you do have some more questions for Dr. Dean. But let's move along now. Mr. Kodka and Dr. McConnell, I think it is now your turn.
Thank you. Just want to check and to see if everyone can see my screen.
Yep.
Okay, excellent. Thank you. Well, first of all, I just want to thank the organizers for this very nice series of presentations. And also thank you to everyone who's here on the call. Today I'll be talking about the in utero exposure to threat of evictions and preterm birth, evidence from the United States, which is a paper that we wrote with Gunther Fink, Ashley Gromis, and Maggie McConnell, who's on the call with us right now. So I think a good place to start is to think about adverse birth outcomes in the United States as a whole. So when we're talking about adverse birth outcomes, what we're usually talking about are a set of outcomes, such as preterm birth, low birth weight, birth defects, post-term birth, high birth weight, and so forth. And the United States actually experiences relatively high levels of adverse birth outcomes, at least in comparison to other high-income countries, such as Canada and countries in Western Europe. And we're concerned about this because adverse birth outcomes negatively impact short and long-term health, which in turn increase healthcare utilization. So the focus of our analysis is preterm births in the US. And I just want to start off with a definition, which is preterm births are defined as being born before 37 completed weeks of gestation. And in the US, approximately 1 in 10 births are preterm, with much higher rates of prematurity among low-income populations. Now, preterm births are of specific concern to us because studies have shown that babies who are born preterm experience much higher risk of developmental challenges, much higher risk of morbidity, even in the long term, and much higher risk of mortality, especially in the short term. So in 2017, preterm births and low birth weight, another very important adverse birth outcome, accounted for approximately 17% of infant deaths. And this is data directly from the CDC, and approximately 60% of NICU admissions. And some slightly older data over here, but the Institute of Medicine estimated that in 2005, preterm births had a societal cost of about $26 billion. So it's a hugely important health outcome for various reasons. And yet, you might be surprised to learn that the exact etiology of preterm birth is still unknown. What we do know a lot better about preterm births are risk factors. And one of the key risk factors that studies have established for preterm birth is prenatal psychosocial stress. And when I'm talking about studies over here, I'm talking about several prospective population level studies that have shown that an increase in prenatal psychosocial stress is associated with an increase in the risk of shortened gestation. And this is after we account for a number of other risk factors as well. So it's this framing that got us thinking about whether threatened evictions could be a determinant of preterm birth as well. And just another quick definition, in our paper, we define the threat of evictions as filing for a landlord-initiated forced removal from a rental unit in local court. And the housing instability literature and the housing literature more broadly suggests that there is a strong link between being threatened with evictions and experiencing elevated levels of stress, depression, and other poor mental health outcomes. But maybe unsurprisingly, very few studies have actually linked the maternal health literature, which talks about prenatal stress, with the housing literature, which talks about threatened evictions and its associations with stress, to look at whether or not we can connect the dots. And that's exactly what we tried to do in our paper by asking two specific research questions. So the first research question we asked was, does increased exposure to threat of evictions in utero increase the risk of preterm birth? And the second question we asked was, does the association between in utero exposure to threat of evictions and the risk of preterm birth vary by pregnancy trimester? Now, ideally, we would want data on evictions, threatened evictions, and birth outcomes at the individual level. Unfortunately, we don't have data on threatened evictions at the individual level, but I think we have the next best thing. So we have data from the eviction lab spanning from 2008 to 2016 on the number of eviction cases filed in local court in each county year month. So for example, we know I'm currently in Montgomery County. We know, for instance, how many cases were filed in local court in Montgomery County in January 2008. Our data on birth outcomes comes from individual level birth records from the National Center for Health Statistics. This is a really well-known data set. And And these birth records were restricted access birth records. So we also had information on the mother's county of residence at delivery. And we used this information on the county of residence to link the outcome data with the exposure data, that is the threatened evictions data. And I just want to also mention that the outcome data also includes a lot of information on maternal demographic characteristics as well as characteristics of the pregnancy itself. And finally, we link the exposure and the outcome data with many supplementary data sources, including data on the county's population, poverty rate, unemployment rate, and we source these data from the Census Bureau and the Bureau of Labor Statistics. All right, so in line with our research question, we define two exposure variables. So the first is the Z-score of average case filing over the duration of the pregnancy. And the second is the Z-score of average case filing defined separately for the first trimester and then combined for the second and third trimesters. And in calculating these Z-scores, we take into account all our data. So our entire time series and all the counties in our data set. As far as outcomes are concerned, our primary outcome is preterm birth, which we define as an indicator variable. But we're also interested in a few secondary outcomes, such as gestational length and birth weight defined in continuous terms, and low birth weight, which is defined as an indicator variable using a standard definition. That is, if a baby is born with less than 2,500 grams birth weight, then we classify the baby as being born low birth weight. Now, as far as our analytic strategy is concerned, we estimated linear regression models with county fixed effects, state year month fixed effects, county-specific time trends, and several control variables. And these control covariates were at the individual level, as well as time-varying covariates at the county level. One of the nice things about our model is that it allows us to make within-county contrasts while controlling for trends in the outcome over the study period at the state level and also at the county level. But one thing I should mention right now is that our model doesn't allow us to make causal inferences. So we try very hard to control for sort of various sources of confounding, but our model doesn't, it doesn't sort of preclude the fact that there's no residual confounding at all in our estimates. So just a quick word on our analytic sample. Our analytic sample consisted of 7.3 million live births from 39 states and DC, which comes from 1,633 counties. And we constructed this analytic sample from a starting sample of about 31.95 million live births from all over the US. And the reason why we lose a lot of live birth observations is actually because we don't have data on the eviction case filings in those counties. And the states that are missing from our analysis are listed here on the side. There are 10 states. They're sort of from all over the US with some concentration in the South. And we list this as a limitation of our analysis in our paper as well. Okay, so let's go get to the results. I will only be presenting the results for the exposure that is defined over the course of the pregnancy, but I'm very happy to discuss the results for the exposure that's disaggregated by pregnancy trimester as well. So as far as preterm birth, our primary outcome is concerned, we estimate that a standard deviation increase in the Z-score of average case filings over the pregnancy is associated with a 1.09 percentage point increase in the risk of preterm birth. And as you can notice over here, the 95% confidence intervals, which are in parentheses, are pretty wide, or relatively wide. As far as gestational length and birth weight, our two continuous secondary outcomes are concerned, you can see that the null value is included within the 95% confidence intervals, and the confidence intervals are relatively wide over here as well. We were able to more precisely estimate an association between average eviction case filings over pregnancy and low birth weight, but also want to suggest that make the point that the confidence interval over here is sort of wide too. Now, our explanation for why the confidence intervals are wide in our study is that we measure, our analysis treats all women within a county as being exposed to a certain level of threatened eviction, regardless of whether they received a notice or not. which means that our exposure variable is measured with some amount of noise. But this limitation in terms of how our exposure is defined ecologically also means that we cannot make inferences about the direct relationship between threatened evictions and birth outcomes at the individual level. Although the results that we see in our analysis right now suggest that maybe stronger associations do exist among women who were personally affected by threatened evictions. Another key limitation of our analysis is that we only observe the woman's county of residence at the time of delivery, so we can't account for whether a woman moves across counties during her pregnancy. We tried very hard to find what degree movement does occur during pregnancy. There aren't very many studies, although a review of the residential mobility literature, one study suggested that pregnant women who do move don't travel very far during pregnancy, with a median distance of travel being under 10 kilometers. And finally, in terms of relevance for social and health policy, I mean, I think I've been harping on this quite a lot already, but it would be great. We need better data and we need individual level data on both the exposure and the outcome, because this would allow us to get more cleanly at a causal identification strategy, and would also allow us to perhaps explore possible mechanisms, perhaps mechanisms beyond prenatal stress as well. And finally, there is an emerging body of literature which suggests that social determinants of health may intersect with birth outcomes. So our research, we believe, suggests that there is a need for cross-silo communication across disciplines in terms of designing and evaluating programs and policies that seek to change, at least improve birth outcomes in the United States. And perhaps we need to think more creatively about existing policies in different domains that can affect birth outcomes as well, and evaluate them rigorously. So with that, I'll just say thank you, pass it on to David. And
yeah, thank you. Just one quick question, and we're going to find that my questions are quite similar across all three presentations, because in all cases you have a complex network of causal and potentially correlated factors, and much of the effort then is trying to disentangle, what causal paths are meaningful and which are not. A policy significance question then, it's kind of interesting in the context of COVID relief. Eviction moratorium has been a policy that both past and looking forward is in that discussion. How far do you think we are from your findings to perhaps some policy like that related to pregnancy? Is there, I understand with your limitations, so we probably can't go right now and say that there's a strong basis, but how would we get from here to there if such a policy was going to be considered? Meaning an eviction moratorium for women during pregnancy?
Yeah, that's a good question. And, I think as researchers, we naturally would fall on the side of sort of, wanting to have more evidence. So from a policy point of view, beyond this study, I think there would be many reasons to pursue, a policy like that based on sort of a wide variety of evidence. I think one of the challenges, as Ayush mentioned, is that this is a county level analysis, so it doesn't fall to the individual level. So that means there are potentially other things about the counties that are experiencing lots of evictions that, that they may also be important. I think the other thing that is a factor here is that this is also potentially a two-way relationship, that there is sort of residual effect that we're picking up of actually the relationship between preterm birth and eviction. I think that's sort of potentially less likely because it usually takes a while from, missed rent payments to getting to the point of eviction. And we're sort of picking up a very specific time period that would be during the first 3 trimesters. So I think that this is an area where additional research would be tremendously useful, and particularly causal evidence around policies that do protect either evaluating the effective policies that protect women or from eviction, which do exist. There are actually many, if Ayush, maybe you can speak to some of the work that you've been doing trying to look into these policies where you might be able to do some quasi-experimental evaluation.
Yeah, so thanks, Maggie. I mean, there are already existing policies that I think we could potentially exploit as natural experiments in order to get at this causal impact that we're talking about over here. An example of a policy that we might want to think about. Actually, let me just move my slides. There are currently policies. There are currently right to counsel laws that are being implemented in different cities around the U.S., with New York being a prime example. And I think there are also just cause eviction policies that are currently being implemented across the country in different cities, I think, jurisdictions. These are things that we could potentially use as natural experiments in order to get at, or maybe using some quasi-experimental strategy to get at the causal effect of evictions on preterm birth or other adverse birth outcomes, which in turn could directly actually lead to policy recommendations, perhaps for larger areas as well.
Yeah, good. Thank you. Just watching our time here. Let me turn back quickly to Austin. We've had some questions come in. Let's tee up a couple of the questions that have come in through the Q&A and see how we do.
Yeah, I'll read some to you. We have several. So let me start with Emma. We have a question. Someone didn't understand why you're adjusting for chronic health conditions because they could be viewed as a result of food insecurity. So could you comment on that?
Yeah, so I mean, in an ideal world, we would know which ones were and were not a result of food insecurity, and that's a good question. So, some of the ones we looked at, things like type 2 diabetes, for instance, could certainly be, food insecurity could be playing a big role in causing them. But on the other hand, we looked at things like cancer. And so cancer, we know, has a high out-of-pocket treatment costs, even if you have good insurance. So that could actually drive a family into food security. That causality could go the other way too. So I think why we were accounting for this is that we wanted to see that that's a channel through which food insecurity is impacting healthcare expenditure. So when we account for those differences in chronic conditions, regardless of what caused them, we don't see these differences in healthcare expenditure. But to your point, in a perfect world, we would love to know which one was causing which. And I think in the future, to the previous comments, better data and more experimentation and more studies would be really helpful there.
Mm-hmm. Okay, thank you. I'm going to stick with you for the moment, and then I'll turn to another speaker. I kind of have a multi-part question.
Okay.
It starts with the parts come together because it gets at the advantages and maybe limitations of the MEPS data source that you were using. And one question is, how would you recommend using those data, if you could, for local or metropolitan area estimates? And I understand there are limitations with MEPS getting down to small geographic levels, but I'll let you answer that. Yeah,
that's a good question. I mean, you can apply for, the state level identifiers, but in terms of local data, I think, MEPS is again meant to be a national survey, so I don't know if it would necessarily be the data source you would necessarily want to use. That being said, we do have, there might be some natural experiments, some things happening in terms of local areas, which would be really interesting to kind of parse out. I mean, I think, again, with MEPS, you can apply again for these state level identifiers. So if there was a state that implemented a policy, for instance, that could be a really good way to go in terms of at least narrowing down that, that population. But I mean, we're also seeing, like with COVID, different areas have been hit in different ways, and we're seeing higher rates of food insecurity there. So I think it's an important question to actually deal with. How are states actually dealing with this in local communities? How are they trying to alleviate food insecurity, and how is that impacting the populations who live there? But probably not the best answer to that question. I apologize.
That's okay. Let's give Asa a turn here. Something I was wondering is, some cities reduced evictions during the pandemic. So there's two questions occurred to me based on that. One is, assuming your estimates are causal, and we'll just put aside whether they are, just if you were to make that assumption, could you make like a back of the envelope estimate of the effect birth outcomes from those policies? Not on the fly. I mean, like in principle, could you do it? And if you have done it, you feel free to let us know. But the other is that related is that do the pandemic-related policies offer a natural experiment that you can think might be exploited in work like this in the future?
Maggie, you want to start?
So I'll answer the second one and I'll let you answer the first one.
Okay.
I think the first one, we could. On the second one, I think there's so much else changing. I think that there are sort of, the natural experiments during COVID make me nervous because those are the same jurisdictions that are doing other things to protect vulnerable populations, and so it is. I feel like we're going to see a wave of COVID natural experiments, and I think it's going to be hard to sort of sift through everything that's happening, and because there's also so many more challenges for families, I think, and including for pregnancies. Like one of the things that COVID is tremendously affecting is prenatal care. The prenatal care has dropped off a cliff, and the impact that will have on preterm birth is substantial. And so I think this sort of eviction moratorium, it would be great if this natural experiment had happened in a non-COVID time but I think there's a reason that it happened now, because low-income families are also so much more strapped, and the consequences of eviction are also greater from an individual and a societal point of view. So for me, that would make it challenging. But I think the back of the envelope calculation is pretty interesting. It would come from a different context, so it might not be as relevant, because you could imagine that actually the consequences could be greater now than they would have been in this estimated study. So, assuming for a moment that the estimates are causal. But go ahead, Ayush, I'll let you answer since you have a better sense.
No, that's exactly right. At one point, think about trying to do something like this, where back of the envelope calculations, we ultimately decided against it, but I think, in principle, it could be done. And with regards to the second question, I think I've been working on some sort of policy analysis for another research, and what I've realized is, and I think this applies to the COVID context as well, there are national level policies, then there are state level policies, then there are local level policies, and trying to disentangle the effect of one policy versus the other, especially in a context with like COVID, where there are so many moving parts, might make, one could potentially do it, but practically, I'm not sure to what degree we could actually use COVID as a natural experiment, just because there are so many moving parts.
Yeah, that makes sense. And I apologize. I think I mispronounced your name, so I'll get it right this time.
Oh, no.
I'll go right back to you. Might be our last question. There may be time for one more, but for the threat of eviction and preterm birth, for your presentation, was race taken into account? And if so, which race was at higher risk of threat of eviction that led to preterm birth?
Yeah, we did control for maternal race in our regression models. We also tried to do association heterogeneity analysis by just stratifying based on race. I don't think we had enough power to be able to get at a very precise estimate. Our estimates for race were, the confidence intervals included the null in most cases, so I don't think we were able to say anything definitive on that front. But what we do know just from looking at descriptive statistics is that preterm birth and all birth outcomes are far more prevalent, unfortunately, among for Black mothers relative to white mothers. The disparities are just incredibly striking. Yeah.
Farouk, I don't have a question for you because you kindly answered the one that came in the chat. So you typed your answer there, and we also are about at time. So David, you want to do the closing word?
Sure, I'll be happy to do that. Obvious strong thanks to our four presenters actually today, for the good work done, and also packaging it in a form that helped the strength of the special issue, and then taking time to do the presentation and answer questions today. This is great. We thank you for your time, and all the attendees. We thank you for your attention and your time. You see on your screen now a website information and a Twitter, what do we call these? A Twitter location. I'm sorry.
Yeah.
I'm exposing my age here. These are ways to stay engaged with this. And a reminder again, next week, I believe same time, there'll be another session like this, different set of papers. So please join us at that time if you can. And I think we've hit top of the hour. Thanks to everyone. Thanks to Austin and the arrangers of this. This has been very good. Thanks to everyone.